Brilliant. So thank you very much for the opportunity to talk here. This is some work I did a little while ago when I was a registrar at King's, and I've since moved to Harefield, where I'm a fellow here, and maybe some of you listening will recognise the office behind me. So I'm going to try and pick out just a few things based on this audit that I did on behalf of ACTACC. So the background and rationale, I'll try not to duplicate, but this tweet from Joe Arrowsmith, who's the president of ACTACC, made me laugh. A bit of a dry sense of humour, but I think he's essentially suggesting that perhaps not all acute type A aortic dissection cases get the experience and care that they need, especially in the middle of the night. So dissections kill more people than RTAs in the UK. There's greater than 500 surgical type A repairs a year, and it's going up. There's huge momentum nationally to improve care for these cases. And this has included, and not limited to, Healthcare Safety Investigation Board reviews, NHS England aortic dissection toolkits, standard operating procedures arising from that. NHS England have now got an aortic dissection dashboard. There's a fantastic patient and relative-led charity that's really banging the drum. And last but not least, we've now actually got a code, separate codes for type A and type B dissection in ICD-11. Previously, there was actually no way for your hospital coders to code two different types of dissection which were treated by different hospital teams. Now, there is some reasonably accepted surgeon volume outcome relationship. And so I think this is, whilst anaesthetists and intensivists are important, I think this is about ensuring that the right patient is united with the right surgeon at any time of the day, at any time of the year, and wherever they happen to have their dissection, and everything really flows into that. So the methods, it was a one-year prospective service evaluation because we didn't have any audit standards to compare to. 351 cases from 28 centres, and initially it was challenging even to elucidate which centres were and weren't treating dissections, because there's 34 or so cardiac centres in the UK, and it was a little bit cryptic at the start. The data was supplied by hardworking ACTACC linked persons in each hospital, usually ably supported by fellows. So results. I'm going to pick out just a few aspects because there's quite a lot of data here. We're going to talk about the escort. We're going to talk about the outcomes. As a nod to our surgical colleagues, we're going to talk about addressing the whole aortic arch in the acute aortic dissection setting. We're going to talk about treating coagulopathy, and we're going to talk about brain and cerebral protection. So, first part, the escort. 18.5% of patients had a medical escort. About a quarter of patients got labetalol. 16% were hypertensive on arrival, but, I note the caution from Dr. Scanlon, a similar number were hypotensive. So you just have to be a little bit careful how aggressively you treat these patients because they may have incipient tamponade. About 1 in 5 had an art line. The only preoperative variable that was robustly associated with mortality in this audit was a GCS that was less than or equal to 12 at any point during the preoperative period. We tortured this data every which way we could stretch it. We ultimately, with 350 or so cases, we were not powered to really answer these questions. You'd probably need 3,000 cases, such as some of the IRAD registry data, to really get at these questions. But in our series, having a low GCS or not perfusing your brain because of your dissection was understandably associated with death. So recently I attended the South England aortic dissection standard operating procedure launch. This was a Friday ago, and this is what they're aiming for. They really are aiming for a medical escort, and ideally one of the acute critical care transfer service escorts that have recently come to the fore in NHS England planning. So access if you're in London, rescue is the 24-hour one in the south of England, which would be supporting this SOP. I think talking to anaesthetists in district general hospitals, they feel that this is maybe a little bit unrealistic with the current levels of NHS staffing. I think for me, what would I want? I wouldn't want to delay a transfer, but I think pain, someone who's confident to manage pain in a potentially unstable patient, and someone who can treat the extremes of blood pressure in an unstable patient would be, you know, that would be my minimum standard. I don't think it necessarily has to be a doctor escorting. So we're getting on to outcomes. This is data for the 19 centres that we had, where we were very confident we had a complete case series across the year. And we can see from left to right, there's a tenfold variation in case volumes from centre to centre. And I think there are some cases, some centres in the UK that are doing more than this, perhaps up to 60 cases a year. And there's also, albeit small numbers, considerable variation in mortality. There are some centres, a couple of centres, that are significantly sub 10% mortality, which is a fantastic achievement. Overall mortality in this piece of work was about 19%, and that's in-hospital mortality. The cardiac surgical data reports 30-day mortality, which is just a touch lower at 17% or so. But I would say overall our data agrees. So addressing the arch, Mr. Ghosh talked about the uncertainties around frozen elephant trunk in the acute setting and how you would do this. Now, this is completely unadjusted data, and I'm not a surgeon. So we have to be mindful that, you know, for patients to have a frozen elephant trunk in the acute setting, you know, their distal arch might have been completely falling apart and there was absolutely no alternative. But in this series, at least, the patients having intervention on their whole arch are younger than those having hemi-arch and interposition grafts. The procedures or the clamp time is modestly longer. They had similar lengths of stay, both in hospitals and ITU, but the in-hospital mortality was double. And there was a lot of early mortality. So about 12 cases died, and 5 of those were on day 0, day 1. So it may be that this is a huge insult to the body. It may be that those cases had really difficult pathology. Probably the truth lies somewhere in between. Of note, I believe there is some work in the surgical literature saying that the aortic root can be addressed without too much additional mortality. In this, those procedures were quite long, and the in-hospital mortality was 19%, as against about 14% for the hemi-arch. Now, talking about blood or products versus potions, there's a suggestion that those full arch cases had a different transfusion strategy than the other cases. So in these cases, they had similar amounts of red cells transfused, similar or slightly reduced clotting products, by which I mean total number of FFP and cryo, but greater numbers were given Octaplex and given fibrinogen. Up to 60% of these patients received fibrinogen concentrate. Now, whether this is just institutional practice, Whether it's consciously product volume sparing, right heart protective strategy, I don't know. One thing I can offer for free is that the vast majority of people, you know, when you're starting cardiac anaesthesia, you don't know how people choose their empirical product strategies. And I can tell you that a huge number of people in this audit abide by the rule of twos. So they give 2 pools of platelets, 2,000 of octaplex, and 2 grams of fibrinogen. And that seems to be the popular recipe. So if that's my cheat sheet for the future, put it that way. Now, someone in the questions previously asked about aprotenin. Fairly equivalent numbers. We're using aprotenin versus TXA in this audit. I have to say, I don't know what the other 8% or so were getting, because I certainly wouldn't do a case without antifibrinolytics, maybe aminocaproic acid, I don't know. But there was no difference in the blood product administration in this data. Again, that's a blunt proxy for bleeding, but nonetheless, there was no difference. So someone was also asking about steroids and what people do. So about 30% give steroids, about 30% give barbiturates. There's a really, really strong vote, more than half the cases, for giving neither of these drugs. And equally, a lot of people, about 16%, get both. If we compare this to historical data, basically my counterparts 22 years ago looked at this and published in Anesthesia, and it looks like thiopental or barbiturate use has maybe halved since those days. Steroid use is about the same. And what we didn't actually ask how many people were giving propofol on bypass or during cerebral perfusion. So I can't really tell you whether propofol use has increased. You know, my impression would be that people feel that there's no point in giving thiopental and propofol. And at that time, when they were talking about protecting the brain, there was a feeling that people were giving it for something to give, and maybe even because they felt that they would be remiss not to give anything, not because they really believed that you should give steroids or barbiturates. And what I would say is, you know, a question to the floor, has this changed in the era of fairly strong use of antegrade cerebral perfusion? Are we now treating a different cerebral insult? So finally, when it comes to the brain, we looked at cannulation strategies and perfusion strategies, and as a comparator, used this excellent publication from Europe a few years ago now, 2015. And we found that compared to Europe, we're not using as much axillary cannulation. In the UK, the femoral is still the predominant choice, albeit not by much. So if you believe that axillary cannulation is the direction of travel, then we are potentially lagging behind, although we didn't look at the interaction between the presence or absence of tamponade and femoral, the use of femoral cannulation. 55% of our cases had ACP versus a massive 91% in Europe. We seemed very good at using NERS, again, if you believe that it's useful and a good thing, so 83%. And about half of the cases were using processed EEG, which I guess can guide both your anaesthetic depth and potentially your cerebral protection strategy. So slightly different to mainland Europe. So to summarize, the ESCORT, I've told you that at this time we weren't meeting those current standards, and the hope that with the use of critical care transfer services, we might better facilitate transfer of these patients. I've told you about outcomes, about 19% in hospital mortality, and that the total ARCH patients are quite high in the 29% range. Talked about product transfusion and how there seems to be slightly different management centre to centre. And I've talked about cerebral protection and how we're probably lagging a little bit behind the changes that are taking place across Europe. So the future, I think increasing awareness is probably the only real way to improve early diagnosis. It's quite an easy diagnosis to miss. And the Aortic Dissection Charitable Trust have done some fantastic work with clinicians, with patients, with relatives, connective tissue disease associations, etc., to further that. Critical care transfer services. I know Rescue and Access are now 24-hour. Rescue have transferred 30 plus acute dissection cases and are going to bring an abstract to ACTACC in July in Cardiff to show everyone how well they've been doing. Shared regional rotas. I don't have a logo for this, but I know this is probably coming down the pipeline. Obviously, the caution is if you jump onto a rota with a hospital that does more than one dissection a week, and you currently do one dissection a month, then that has very significant implications for the service. And also other activity in your hospital. For example, at Harefield, we're quite often doing transplants in the middle of the night. And I don't think it's happened yet, but what happens if we're on call for dissection as well? It could be difficult. Randomized data. I was excited. I don't have a hotline to these, the Canadian group, but I was excited to see that there is the Titan Head Start trial, which promises to be some of the first randomized controlled trial data in acute aortic dissection, and it is addressing this question of whether you need to do the whole arch or whether a hemi-arch is an adequate or safe operation. And finally, more governance. We've talked about coding. I think there's variation here that no doubt the GIRFT people will be all over, aiming to minimise and drive improvements that way. And obviously the NICOR, the National Cardiac Surgery Audit, have very good quality data, and hopefully that will drive further improvements. Right, so thank you to all my co-authors and all these people listed in bold who weathered my large case report form, and thank you for all their hard work, and I'd love to take any questions.
Thanks very much, Tom, and thanks for your hard work putting all that together. And I know you've kind of talked us through it, well, either here or at ACTACC a couple of times now, but it really is an impressive piece of work, and it must have been a lot of effort for you and your team. One question I had was, did you see that there were definite institutional trends, or was there a lot of inter-individual trends within institutions?
It's very difficult to say because we didn't have individual surgeons' names attached to cases. So it's hard to pick those two apart. I'm sure the cardiac surgery audit people in Bristol have access to that data. However, we did see very clear institutional trends. For example, several institutions are doing large numbers of frozen elephant trunks. One institution uses a lot of retrograde cerebral perfusion, whereas few others seem to do it routinely. A couple of institutions did 50 cases, between them, and, basically all the same procedure, all hemi-arch, very, very consistent strategy. All the audit cases look very similar with very good outcomes. So, yeah, there's definite institutional trends. Nova 7's another one. Very few patients got Nova 7 and they all came from the same centre.
And do you feel like it's changed your kind of future practice for managing dissections based on having done this work?
Yes, although it's led to some frustrations. I really don't have a clue how we best mitigate cerebral injury during these long cases, and I don't think our audit data has shone any light on it, other than it probably hasn't changed that much in 25 years, and we're still doing some of the same old stuff. But certainly I've learned a lot of things, and a lot of the surgical aspects that I've had to understand through going through these cases and tidying up the data have been very instructive.
It's a fantastic piece of work. Any questions for Tom in the chat? Or anybody else want to raise their hand and ask a question? Please feel free to do so. I did have something else I was going to ask you, but it's completely slipped my mind. Dr. Shepherd has put his hand up.
Hello, thank you for the talk. I just wanted to come in on your comment about the quick care transfer services. So I'm the clinical lead for Access. Aortic dissection accounts for about 2% of our workload within London. We've done about 2,000 referrals this year. So we're averaging a reasonable number of moves, both type A and type B. And I just wanted to come back on the bits about your point that actually most of what we find that our staff are needing to do is exactly what you say, it's pain relief, but there's actually quite a lot of hemodynamic titration. As you say, they can be quite nuanced. We certainly picked up people who are under resuscitated or indeed who are tamponading where it hasn't been recognised. So I think actually broadening some of the scope of what the quick care transfer services may do about pointing towards the right hospital or helping kind of advise about location, which is something that we've certainly learned within London, and I think speaking to colleagues across the country is pretty similar. It would be really beneficial for some of these patients.
Yeah, thank you. I think, you know, we forget working in cardiac centres that we feel we have a handle on treating these patients, but actually a lot of the same transfer professionals are also cardiac anaesthetists and so on and so forth, and they can really take some expertise to the patients rather than just be a conduit, if you like.
Fantastic, thanks, Tom, and it's great to see another shout out to Dr. Mattison for the CAT meetings. He seems to get mentioned in every meeting that we've had for the past 3 or 4 months. I'm sure he'll be very pleased.